Thank you very much. We're doing this on a little bit of short notice, but I had this lecture ready for next week when I'm speaking at the London Vet Show. So today I was asked to present about point of care testing for thyroid disease in dogs and cats. So we're going to talk primarily about hypothyroidism in dogs and hyperthyroidism in cats. And we're going to start by let's see, why is my thing not going here? Here we go. So the technology behind this point of care testing from Zomedica, the Truforma technology, is that it's actually based on highly sensitive bulk acoustic wave technology. And the way it works is you get a little disposable cartridge. The machine is shown there on the right over here. And it's a small machine that sits on your counter in your vet practice. And the way it works is that it looks at a shift in frequency when antibody binds to the analyte. So for this example, we're going to be using total T4, endogenous TSH, free T4 as our tests that we can run on this machine. And it takes about 15-20 minutes. And so we can have an answer for our clients pretty rapidly. So let's start by talking about canine thyroid disease. The most common form of that condition in dogs is lymphocytic thyroiditis, which is similar to Hashimoto's thyroiditis in people. It does have a genetic basis. By the time the lymphocytic thyroiditis has been present for several years, generally the thyroid will undergo atrophy because it's been constantly, what's the word I want to look for? Constantly damaged over time. So it's kind of a piecemeal damage, and eventually the thyroid gland will disappear. Neoplasia isn't very common, and we do see some congenital forms of thyroid disease in the dog and puppies, but for the most part, almost all, probably 99% of thyroid disease in dogs is hypothyroidism, which is immune mediated. So the way it develops is that there's a genetic predisposition for the condition. And you can see in these slides here, we have somewhat normal thyroid area right here with all the colloid. And then we have an area that's blown up here where there's lots of fibrosis and everything. So that whole situation of cell-mediated immunity damaging the thyroid gland, which leaks the thyroglobulin. It's a real big protein, so the body reacts against it and develops antibodies to it. And those antibodies feed back and eventually lead to a lymphocytic, plasmacytic destruction of the thyroid. This is a condition of young to middle-aged dogs, and actually you can see it in quite young dogs. I've diagnosed it in dogs as young as 6 months of age, and I'm not talking about the congenital forms here. This is lymphocytic thyroiditis. And you can see that subclinical thyroiditis, which is shown in the sort of fuchsia color here. It can start as early as like 6 months, and it reaches a peak at about a year of age and then starts to tail off. So the damage is generally done in the subclinical situation. All you're going to see, you're not going to see symptoms. You're just going to see these antibodies in the blood. So antibodies to thyroid globulin. Then the actual lymphocytic thyroiditis sort of kicks in at about a year of age, and then with a peak at about 3 years of age. And then finally, for the destruction of the thyroid gland, complete destruction, you're going to get a peak at about middle age of about 6 or 7 years of age in dogs. So this data is taken from 143,000 samples. So they had a nice sample size to look at these different things and in each of these categories. So you can see how the disease develops over time. It is a genetic disease. It has a genetic basis. And the breeds that are most commonly affected, Golden Retriever, Dobermans, Dachshunds, Shar-Peis, Cocker Spaniels, Shelties. The genetic basis is actually a change in the genetic information in a certain allele that is also shared with diabetes mellitus. So we can see these two endocrine diseases together. And then, of course, on the right-hand side, we have breeds like boxers, miniature and toy poodles, Great Danes, etc. That can be affected. So whenever we're doing testing for thyroid disease in the dog, we want to have clinical signs that we are testing the dog for this condition. Not all of them are going to look classically like this. Cardinal signs are this tendency to generalized obesity, a thinning of the hair coat, particularly on the trunk of the body, mental and physical lethargy. This becomes important in dogs that are performance type dogs. So if you consider agility dogs, police dogs, hunting dogs, fly ball, all these different things, little jobs that dogs do. Those dogs, you'll notice a change in their training. They'll get tired faster. They won't have the stamina to work in a field if it's a hunting dog. So the mental and physical lethargy part of it can be kind of difficult to tease out. A lot of times people think their dog's just getting older. And then finally, in breeding animals, infertility has been reported associated with hypothyroidism. Although it's not a direct effect, it's actually a situation where multiple endocrine organs within the body, including the thyroid, sometimes even the adrenal glands, parathyroid, the pancreas, and then the ovaries and testes, which are, endocrine organs. Those can be affected with the lymphocytic, plasmacytic infiltrates. So it's actually, the infertility is kind of a bad situation, because if you diagnose the dog with hypothyroidism and they are infertile, they probably won't become fertile if you put them on thyroid medication, because it's not a direct result of a deficiency. So some of the other clinical signs that we can see is that sort of coarse, dull coat and excess shedding, exercise intolerance, as I mentioned in our performance dogs, a tragic facial expression or myxedema, hyperpigmentation in the skin as a result of the alopecia, cold intolerance. I always ask my clients, does your dog seek out warm areas in the house? Like, does it lay in the sun or does it lay by the refrigerator because it's warm at the bottom of the refrigerator? I mentioned repro abnormalities, and occasionally you'll see bradycardia, but that's about 10% of the cases. So that's not a common clinical sign of hypothyroidism. Probably the most common one that you'll run into as a veterinarian are dermatologic issues. So that's symmetrical alopecia, although some dogs can have asymmetrical alopecia, but most of them are symmetric. Dull, dry hair coat, seborrhea, a puppy hair coat. Sometimes they can develop recurrent pyodermas, and so they are at risk for methicillin-resistant staph. Recurrent otitis. I would say this is the most common thing I see as an internist in my patients that are hypothyroid. Recurrent Malassezia infections, tragic facial expression, and the skin, in comparison to, say, a dog with Cushing's disease, will be thickened and cool to the touch, and there'll be a lot of mucin deposition in it. So that's what gives it the thickness. And our dogs with Cushing's disease will have really thin, almost paper thin skin. And then the other thing that people often notice is poor regrowth of hair, especially if it's been clipped recently. As an internist, many times I have dogs referred to me with diabetes, for example, and I'm going to be looking for certain things in the clinical pathology to make sure they don't have hypothyroidism as well. So our hypothyroid dogs are going to have lipid abnormalities, primarily hypercholesterolemia and hypertriglyceridemia. Now, my laboratory, my in-house laboratory, doesn't actually run triglycerides. And I think a lot of us, depending on what laboratories we use, sometimes they're included in the panel, sometimes they aren't. But hypertriglyceridemia, I think, is really the most common clinical pathology change that I see in hypothyroid dogs. Sometimes they can develop anemia. About 25% of them will have a normocytic normochromic anemia. About 30% will have low sodium. They can have elevated ALP. And so a lot of times we're kind of keyed into checking for Cushing's disease when we see an increase in ALP. But hypothyroidism can do that as well as a result of the hypertriglyceridemia. Clearance of lipid through the liver is going to affect the ALP. And then finally, about 25% of them will have an elevated creatine kinase. So let's look at a case here. This is Graf, who was affectionately known as the house hippo. He was a 5-year-old male castrated Rottweiler. He was gaining weight. He was lethargic. He had topped out at 182 pounds with a body condition score of 7 out of 9. He eats 1 cup of RD. And of course, when I asked the client, I said, are you using a regular cup? And they actually showed me the cup, and it wasn't like a big jumbo cup that they were feeding him. And he lives on a ranch and he eats a lot of horse poop too. And one thing they did mention was that he likes to lay by the refrigerator. So this is kind of like, this would be a classic hypothyroid case that might come into your clinic. Let's see what kind of testing we did. We did full testing on this dog, but I just want to point out a few things. So if we look at the minimum database, the dog has a mild anemia, the Paxil of 25. This case was in Colorado, so it should have been higher than that. His total T4 was low on a panel. It was included in the serum chemistry panel. His chemistry numbers show a cholesterol of 735, so that's elevated, high triglycerides, low sodium, high CK. So he has all of the clinical pathology changes that we would expect in a hypothyroid dog. And when we look at his panel, you can see that his total T4 is low, his T3 is low, his free T4 is low, his TSH is high from a lack of negative feedback, and he has no thyroid autoantibodies. So in this case, we have a dog that is very classically hypothyroid by the look of him. It's a breed that we often see hypothyroidism in. We did a CBC, he's got the anemia, he's got the lipid abnormalities, et cetera. So we're thinking, okay, this dog is probably hypothyroid. And, if you don't even necessarily, if you're not sending things out, you wouldn't get that total T4 that I got on this particular panel. But, you're looking at your panel and you see these lipid abnormalities. This is a great place to use a total T4 or a free T4 if you want. But I usually start with a total T4. And as you can see, all of these are consistent with hypothyroidism. So let's talk about total T4 and what the advantages or disadvantages are. And this is from a study that was done many years ago by Mark Peterson. And they looked at it. The reason I use this slide is it really shows you some of the aspects of total T4, free T4, and TSH, which we'll talk about, that some of the other studies don't. So graphically, it's easy to look at. So they looked at 150 normal dogs, and the green area is the normal range for total T4 in nanomoles per liter. And these are whisker and box plots. So we're seeing median, standard deviation, and then the range here. And then the little dots at the top and the bottom are outliers. So 150 normal dogs, most of them fall within the normal range for total T4. We have one outlier that's a little bit high. Of the 54 hypothyroid dogs, almost all of them are in or below the normal range, below 12 nanomoles per liter. But there are a few, there's 3 of them that are just in the low normal range. And then we have some up at the top here that are quite high. And those are probably T4 autoantibodies, not thyroglobulin autoantibodies that I mentioned before, which is characteristic of young dogs with hypothyroidism. But sometimes you do get antibodies to T4, and that's what we're looking at there. And then our euthyroid sick dogs are shown here in the suspected area. And you see that there is quite a bit of overlap here on the standard deviation between dogs with non-thyroidal illness and those that are hypothyroid. So those are the ones that if your T4 comes back in the normal range, or if it's real high and you still suspect it has symptoms of hypothyroidism, you're kind of scratching your head like, how can that be? Well, it can be a result of antibodies, but they will still have the symptoms of hypothyroidism. Okay, let's talk about free T4 now. T3 and T4 are secreted into the bloodstream where they're highly protein bound. So 99% of them are bound, and they act as a reservoir for the cells. So when the T4 diffuser or T3 diffuses off of the protein and then it goes intracellularly, that's what we refer to as free T4. And that's only 1% of the total T4, which is the T4 is serving as a reservoir. So free T4 is a little more sensitive than total T4 when we're looking at hypothyroidism. So again, the same dogs, but in this case, we're looking at serum-free total T4 in picomoles per liter. Again, the green is the normal range. And you can see of 150 normal dogs, almost all of them are in the normal range. There's a few that are above the normal range, some outliers there. And then we see that the hypothyroid dogs, there's almost all of them are below the normal range. We have one little outlier there. And then our euthyroid sick, we don't have that overlap of the standard deviation here. So free T4 is going to be able to tell you whether or not the dog is euthyroid sick or truly hypothyroid. So I use it as a follow-up if my total T4 is not telling me what I need to know about this dog that I suspect has hypothyroidism. Now, there are a lot of free T4 assays that are available commercially. The free T4 by equilibrium dialysis is a test that was initially optimized for human use and then later adapted for veterinary use. It is a radioimmunoassay, so it has to be done in a special laboratory so they can get rid of the radioactive tag. It is not automated. It is a manual test. And for that reason, the precision is not good. It has poor reproducibility. It has to be incubated overnight, and the turnaround is 2 to 4 days. So that's not ideal. The new free T4 that IDEX developed is actually a chemiluminescent immunoassay. It is veterinary specific. It measures light emission. And it's automated, very reproducible. So this test is what the Zomedica Truforma bulk wave analysis test was compared to, and I'll show you the results of that. So the Truforma assay, free T4 assay, was compared to the Imulite, which is what IDEX uses, the chemiluminescent free T4 assay. And you can see that we have a correlation coefficient of 0.93, which is excellent. and the Blandman-Altman bias plot. I don't use these very often, but they basically shows that it's very highly correlated. They're two different tests that give you that. So we know that the free T4 assay that we're using as a point of care test compares favorably to the laboratory tests, and there's good agreement there with the chemiluminescent method. Well, what about TSH? So if we look at TSH, which should be high in a hypothyroid dog, we have here examples of the hypothyroid individuals as a square, and then the euthyroid sick or non-thyroidal illness or just truly euthyroid dogs are in the yellow circle. So what this graph is showing is it's a analysis of TSH on the vertical axis and free T4 by dialysis in this case on the horizontal axis. And you can see that almost all of our hypothyroid dogs, we have a few down here, but most of our hypothyroid dogs have a high TSH and a low free T4 by dialysis. Now, the reason I have this yellow line right here, instead, I'm using this yellow line instead of this white line here. The TSH assay has been refined over the years, the endogenous TSH. And we used to have a cutoff of 1 nanogram per mil, and now the cutoff is more like 0.4, 0.5, depending on the assay. For the true form, I think it's 0.5. And you can see that we're capturing even more of those hypothyroid dogs here when we change that cutoff to the one that we use now, which is 0.5. And so then we have these other dogs here that were categorized as either euthyroid or euthyroid sick, non-thyroidal illness. And you can see that some of these dogs have a low, well, their TSH is actually, if we use the yellow line, I'm only talking about these right here. They have a low normal free T4 and a low TSH. Now, we don't know if those dogs could be having transient reductions in their TSH. That can happen with non-thyroidal illness. We also don't know, even though most dogs with hypothyroidism are primary hypothyroid dogs, meaning it's destruction of the thyroid gland, there are a few that actually have pituitary disease. So the TSH and the being low could be that there are secondary hypothyroids. So in general, the free T4 by dialysis, or excuse me, just the free T4, because we know that most of the free T4 values correlate well. If we compare it to TSH, I'm more of a fan of TSH because that's what they use in humans. A lot of people like to use free T4, but I don't think you have to use free T4 by dialysis because it takes a long time to get it back. So having this point of care free T4 is helpful. And a lot of times, if I'm screening a dog, it already has had a normal total T4, and someone's referring the case to me, for example, I'll run both the TSH and the free T4 and see if I come up with an answer on either one of those. And that's kind of how I will do these tests. And in terms of the cost for the owner, I think it's very reasonable. I usually have the clients, agree to this type of testing, and they are also very happy to get an answer right away, basically. The other place where I use point of care testing is when I have diagnosed hypothyroidism and I'm thinking of monitoring my therapy. So the supplementation, the thyroid hormone supplementation can be monitored with either an endogenous TSH or a post-pill total T4. I'm generally running that 4 to 6 hours after the dose if I'm doing a post-pill T4. And I like it to be in the high normal or just above the normal range for the T4. If I've made a diagnosis of hypothyroidism based on an elevated TSH, though, I a lot of times will go ahead and monitor TSH. And the advantage of that is that no matter how many times you tell the client, I need you to give the pill at 8 o'clock, and then we're going to bring him in at noon for his post pill. A lot of times they forget to give the pill, or they're unsure whether they should have given it and they didn't. So the advantage of TSH is it can be done at any time of day, and it's not affected by the time of the dosing of the total T4. And I usually will start with BID dosing 22 to 44 micrograms per kilogram. So I do 22 micrograms per kilogram twice a day for 4 weeks. And if they're in the range that I like it for the TSH, I want the TSH to be suppressed. And I'll show you this slide in just a second. If it's just at the normal, high normal, or just above normal on the post-pill T4, with BID dosing, I then go to once a day. I've occasionally had dogs, though, that after I went to once a day, they didn't do as well on their thyroid supplement. So another place you can use the total T4 from the Truforma is to do trough levels just before the next dose. So let's say the dog was put on once a day thyroid meds. You want to see if it's lasting 24 hours. So I would like to see a trough level in the normal range for total T4 just before the next dose to know that they were adequately supplemented. If they're dropping below that, then I would probably go back to BID. Now, the slide here on the right is a dog that has been made hypothyroid by radioactive iodine ablation of the thyroid. And you see that the TSH is quite high, and it drops down once they initiate therapy of 0.025 milligrams of levothyroxine. And you see it completely suppresses that TSH below 0.5. And then here they take the dog off of the thyroid medication, and you see that the TSH rebounds back up and reaches, well, close to the initial level by day 70, so about 30 days later. So for those of us that maybe see a case that's already been put on thyroid supplement and you're not sure that the dog actually is hypothyroid, you could test him after stopping the thyroid hormone supplement. You could test him 30 days later and see if the TSH is elevated and if they are truly hypothyroid. You could also do a free T4 as well. So either those, and you have all three of those testing possibilities with the Truforma. This is a case I saw that was taken off of their thyroid medication. It was on 0.8 once a day. It's a big German Shepherd, about 80 pounds, 90 pounds. And he had developed epistaxis 3 weeks ago. So they took him off of his thyroid medication completely. I retested him, and his total T4 was undetectable. His free T4 was low normal. And his endogenous TSH was, although it was within the normal limits, it was at the high end because my cutoff is 0.4. So, and with this testing sample, so 0.34, that's right, fairly close to 2.4. So I went ahead and said, yeah, this dog is definitely hypothyroid. We put him back on a lower dose of 0.4, rechecked him later in 2 weeks, and he was adequately supplemented. However, a year later, the dog came in and was put on some sort of antihistamine, I think it was. Anyway, it was something that elevated the dog's blood pressure. And what happened was the dog developed epistaxis again, and we found a nasal tumor, actually. So it's very rare that I see dogs over supplemented on thyroid meds. But this was a case where, it was sent to me for that condition because it had gone to the emergency clinic when I initially saw it. So I was following up. And it turned out that actually the dog wasn't over supplemented on thyroid hormone because that wasn't what caused the epistaxis. All right, let's move on to cats and what testing is available for them. And here we're going to be talking about hyperthyroidism, which is the most common feline endocrine disease, 1 in 10 geriatric cats. Generally, these are benign adenomatous hyperplasia, 75% of them bilateral, and you can usually feel goiter in these cats 80% of the time. Malignant carcinoma is not common, but I have seen it develop in cats if they're on long-term methimazole. So you can get an adenomatous hyperplasia can actually progress to become a malignant carcinoma if you're keeping them on methimazole for long periods of time, several years, for example. The clinical signs of hyperthyroidism, the physical exam palpation of an enlarged thyroid gland or goiter, increased appetite, polyphagia, polydipsia, polyuria, weight loss, hyperexcitability, the cardiac signs of murmurs or gallop rhythms, tachycardias, and some may present in congestive heart failure. Those cats are usually pretty advanced, though, so we don't see those very often anymore. GI signs such as vomiting and diarrhea, and then, of course, polyuria from the primary polydipsia. Generally, we'll do a minimum database, and then we have a choice of several thyroid hormone testing. We can do total T4, and I believe the Tuforma team is working on a free T4 for this test for cats. We don't have one yet, but I believe they are working on it. We can ask at the end here if that's the case. So one of the advantages of the Truforma is they do have a feline optimized TSH, which is available now. So T4 and the feline optimized TSH. So we'll talk about those. When I'm looking at the minimum database and I suspect hyperthyroidism, I'm going to look for an increased hematocrit. They sometimes will have large platelets, but the primary chemistry finding is going to be an increase in ALT, and it's usually much higher than the other liver enzymes. So they can have some increase in ALP, but if they do, it's not nearly, usually the ALT is 2 to 3 times what the ALP is. And some of them may have azotemia at the time of presentation as well. On the urinalysis, they may or may not have a decreased urine-specific gravity, but they usually have proteinuria because most of them are hypertensive and have some glomerular hypertension too. So when we are looking at hyperthyroidism, what happens with the thyroid gland is as the thyroid gland becomes adenomatous, and there's been lots of research on what causes this disease, so I'm not going to go into detail on that, but I think one of the primary things that they think may be causing this change in the thyroid gland is flame retardants that are used to, prevent fires from rugs or furniture and things like that. So there's a whole theory about how these compounds can accumulate in the thyroid gland and lead to this adenomatous change. But essentially, what we have is, in the case of hyperthyroidism, an increase in T3 and T4, free T3 and free T4 as well. And that's going to feed back and suppress TSH. So the opposite of hypothyroidism, where you have a low T4 and T3, which causes a high TSH. This is a negative feedback where the high T3, T4 is going to suppress TSH. So if we look at this study, again, this is a Peterson study looking at a large number of cats with hyperthyroidism, some with non-thyroidal disease, and then normal cats. You see that normal cats generally have a serum T4 in the normal range, which is in this sort of turquoise green color. The hyperthyroid cats, 90% of them are going to have a high total T4 value. But we do have some outliers here, if you notice down here, and these can be problematic when we see them in the normal range. And then cats with non-thyroidal illness will show, similar to dogs, that they have kind of a mild depression in their total T4. So why would a hyperthyroid cat have a normal total T4 value? Well, it could have subclinical disease. It could be a normal thyroid fluctuation. It could be a non-thyroidal illness superimposed on hyperthyroidism, which would suppress the T4. And of course, there are a variety of medications, primarily steroids, phenobarbital, sulfa antibiotics. I have a cat right now that the cat has cardiac disease, it's PUPD, it's losing weight, it has every clinical sign of hyperthyroidism, but it's on steroids and chlorambucil, I think, for its, it was diagnosed with IBD or lymphoma. They didn't biopsy, so they didn't know. So I'm kind of in a quandary here because I have a cat on steroids. How am I going to diagnose whether it's developing hyperthyroidism or is hyperthyroid? And that's a problem. This just illustrates the normal fluctuations of serum T4 and T3 in an individual cat. And you can see that if you measure the T4 on day 1, you would conclude that the cat was hyperthyroid, which it is. But if you happen to catch it on day 4, you can see that the serum T4 is actually in the lower end of the normal range, and it's kind of hanging out there for a while until it goes up again about 11 days later and comes outside of the normal range. So we can get these fluctuations. So total T4 isn't 100% for diagnosing hyperthyroidism. And then we also know that T4 will decrease with the severity of non-thyroidal illness. And in this study, you can see as you go from mild to moderate to severe concurrent illness, the T4 drops dramatically. And the free T4 really doesn't. So there, we'll talk about the free T4 next. But then if you have if you're looking at TSH, you can see that it is relatively unaffected by the non-thyroidal illness. Although you do have some outliers here, up here, and you have a few up here with the free T4. So there are some things we don't understand about hyperthyroidism and non-thyroidal illness still. And it can be kind of tricky to tease this out. So what kind of tests do we have? Well, we can look at the serum free T4, which is the next test we're going to talk about. And this, if we look at serum free T4, our normal cats are in the normal range. 98% of our hyperthyroid cats have an elevated free T4, with only 1.5% being in the reference range. And then our cats that have non-thyroidal illness or superimposed illness on hyperthyroidism, or excuse me, on a normal cat, excuse me, you can see that some of the free T4 is elevated. We don't understand that. We don't understand why we get these spurious elevations in cats that have non-thyroidal disease. But some people think it has to do with protein binding, since the free T4 is actually the T4 that is coming off of the protein bound total T4. All right, so let's look at TSH. And TSH in humans, the first test, that's the first test they would do for you to diagnose if you're hyperthyroid. And the problem that we've had in the past is that the TSH values that we see in hyperthyroid cats are below the level of detection of the current canine TSH assay. So you have to optimize that assay to look at TSH in normal and hyperthyroid cats. And you can see that there's quite a bit of difference here. Our hyperthyroid cats are quite suppressed on their optimized TSH, whereas our normal cats are generally in the normal range for this assay. So the overlap is really not much. And although I don't have it in this slide sample that I'm presenting right now, or the slideshow, there was a recent paper by Dr. Mark Peterson where he also looked at TSH in cats with non-thyroidal illness, cats with, I think he did cats with kidney disease as well, because he has another paper on the survival of cats with kidney disease and hyperthyroidism. But in that paper, he also shows that the subclinical hyperthyroid cats will show this suppression in feline TSH, or the optimized TSH. A study out of, I believe it was out of Bristol, someplace in England or Scotland, it was Glasgow. At any rate, they looked at cats. They had collected samples in cats over several years. So they could go back and look at the samples. And when the cat developed hyperthyroidism, they had this group of cats, I don't know, it's 12, 15 cats, something like that. And they saw that if the cat developed hyperthyroidism, they went back and looked at the TSH in those cats in the year preceding it, or 2 years preceding it if they could. And they found that the TSH is suppressed about a year prior to the cat developing overt hyperthyroidism, clinical signs, and a high T4 or free T4. So if we're looking at the possible scenarios that we might see, so if we have a classically hyperthyroid cat, the T4 is high, it has clinical signs consistent with hyperthyroidism, vomiting, weight loss, etc. And we're going to initiate treatment and start monitoring the cat. So then if we look at the next scenario, you have a cat that's possibly hyperthyroid and it has non-thyroidal illness. So maybe you've documented it's diabetic or it has chronic renal disease, but it has signs that are compatible with hyperthyroidism, but a normal T4. In that case, you're going to either recheck the T4 because it might be a fluctuation, a normal fluctuation, or you could also check the TSH. And because you have the point of care test, you can do that in your office. If they have a palpable goiter, but they have no clinical signs and their T4 is normal, same thing, recheck the T4, or maybe the second time you check TSH. If you have a cat that has subclinical hyperthyroidism, the T4 is increased, there are some lab changes. You can recheck the T4 or check the TSH. So the subclinical, so maybe it's like borderline high and you're not sure. So I might go ahead and check the TSH in that case, because we know that the subclinical cats will have TSH suppressed about a year before they develop clinical signs. If you have an increased T4 and a known non-thyroidal illness, then you're going to initiate treatment and monitoring for the hyperthyroidism and for the concurrent disease. And if the T4 is increased, no clinical signs, no goiter, and the cat is clinically normal, I would pursue with either rechecking the T4, because again, it could be a fluctuation, a normal fluctuation where the cat's spending most of his time in the normal range, but you just happen to catch it as high, or you could check a TSH. And I'm going to give you an example of a case that I saw, and this cat, Mikey, 3 kilograms, body condition score of 5. He's been PUPD polyphagic for 6 weeks, and his heart rate is 200 beats per minute with a gallop rhythm. The cat is stressed in the exam room, and his pupils are dilated. He has a temperature of 102.5, but I cannot palpate a T nodule, but the cat is very stressed. So I'm not going to try to kill the cat to feel, whether it has a goiter. So I'm just going to back off, get a fear-free blood sample if possible. And on clinical pathology, we see sort of classic erythrocytosis, macrocytosis, stress leukogram. Total T4 is in the normal range. Cat is diabetic though, and mildly azotemic, has low cholesterol. That's another thing you can see with hyperthyroid cats, so opposite of hypothyroidism. And it has increased liver enzymes. So this cat, we went ahead and treated the treatable. We knew it was diabetic. I started him on a low carbohydrate diet and insulin, and the cat did well. They were able to reduce the insulin dose to 1 unit twice a day. I started at 2 units twice a day. But the cat continued to be PUPD despite drops in blood glucose. And in fact, as you can see in the curve, the cat got down pretty low. So it's definitely not PUPD because of the glucose per se. I mean, yeah, it's high up here, but the owners were still concerned because it was continuing to lose weight and ravenous. And this time the cat is calmer, and I can feel T nodule on the right side. And we see that the total T4 is high and the optimized TSH is quite low. So anything below 0.03 is consistent with hyperthyroidism. But what about hypothyroidism in cats? Does that occur? Well, most commonly it occurs as a result of radioactive iodine therapy for hyperthyroidism. So other applications for the feline TSH is to monitor post-treatment. So iatrogenic hypothyroidism can occur in upwards of 50% of cats treated by any modality. It can occur with methimazole, thyroidectomy, or I-131, but I see it most commonly with I-131. Clinical signs may not be appreciated because hypothyroid cats, unlike dogs, they don't do a lot of exercise, not a lot of performance cats and things like that. They don't get the skin changes that dogs do. I didn't want to go into a whole lecture on hypothyroidism in cats, but classically, we've assumed that their low T4 values post-treatment are due to non-thyroidal illness. But if you're doing a T4, it's often, even though it's low, it's may still be in the normal range, and 80% of cats with hypothyroidism can be missed. So we'll go back to our other cat, Mikey, and he was put through I-131 treatment for his hyperthyroidism, and he was rechecked 2 months after that. He had gained his weight back. The owners discontinued the glargine, and that's common if they have both conditions. Once the hyperthyroidism is treated, the diabetes goes away. The glargine was discontinued because his blood glucose was normal. And then they started giving him over-the-counter dry food, and he started with PUPD again and was acting diabetic. He came in with a temperature of 99 degrees and a pulse of 130. Serum chemistry showed severe hyperglycemia, an elevated fructosamine, high cholesterol and triglycerides, moderate azotemia. Total T4 was undetectable. and the feline optimized TSH was 4 times the upper limit of normal. So pretty classically hypothyroid and diabetic again. And what we did is we supplemented this cat. So the whole azotemia following treatment of hyperthyroidism, so iatrogenic hypothyroidism. Azotemia is really common in our hypothyroid cats compared to the euthyroid cats. And we also know that hypothyroid azotemic cats have a shorter survival rate compared to non-azotemic cats. So restoring medically treated cats to euthyroid and reducing their plasma creatinine concentrations and resolving the azotemia occurs about 50% of the time when you supplement them, but there is 50% of them that have to remain on thyroid supplements. So that's just one thing to consider and to look for in these cats. So I'm at the end. This is my little Trueforma machine that we keep. That might be the old one. I think we have a new one now. And I'd be happy to answer any questions.